Yes, ma'am.
Okay. So, good afternoon, everybody. Very warm welcome to all of you on today's FOG webinar titled Double Trouble, where we'll be brushing through the twin pregnancy guidelines. I'm Dr. Shweta, consultant A4 Hospital, who will be moderating today's session. So, as we can see, twin pregnancies are increasingly common these days in our practice, probably because of the advanced maternal age or the use of fertility treatments, especially IVF. And also, along with the joy of seeing two babies on ultrasound, we do have our own fair share of challenges and dilemmas. Some aspects of twin pregnancies they seem so basic, yet even experienced obstetricians can find themselves pausing for some time, wondering whether we are labeling the twins correctly, whether we are accurately giving the chorionicity, whether we are interpreting the aneuploidy screen reports correctly, whether a particular growth discordance value is truly concerning at a particular point. So there are lots of these questions around dating, chorionicity, the monitoring protocols, how to counsel patients for follow-up, for fetal reduction procedures, and these usually come up more often than we think. And so this session is exactly to address all our dilemmas. We are truly privileged to have with us Dr. Shivani, who is a leading fetal medicine consultant. Ma'am brings with her immense expertise and clarity in handling these gray zones. So today she will walk us through the key aspects of managing twin pregnancies, the latest guidelines and all that. So a short introduction on Dr. Shivani. Madam is a consultant, fetal medicine specialist at A4 Hospital and Fertility Center. She's also a senior consultant at Sri Ramachandra Medical College. And ma'am is a trainer in fellowship for fetal medicine in Srihar. Her special interests lie in fetal therapy, fetal interventions, and first trimester imaging. And ma'am has coordinated various ultrasound workshops. And she's a clinical lead for multiple pregnancy clinic and fetal interventions at our hospital. So over to you, madam. If the participants have any doubts, I request you to put it in the question box, and we can also have a discussion at the end of the session. Over to you, madam.
Thank you, Shweta. Is my screen seen?
Yes, ma'am.
Yes, ma'am.
Yes, thank you. So,
Double click on the slide, ma'am, to change the slides.
yeah, but the screen is not going for me now. Okay. So, as Shweta was briefly describing how we are going to manage twin, it is a double joy, but yet it is a double trouble too, both on maternal and on the fetal aspects. So I'm just going to run through the very basic concepts on a role of ultrasound in managing twin pregnancy. The recent ISWA guideline added to on from 2016 to 2025. So what additional features we are going to see and how are we going to manage these twin pregnancies? So the incidence of multiple pregnancy worldwide owing to increased assisted reproductive techniques, increasing in maternal age, and this has caused high risk of perinatal mortality and morbidity as we are facing this in everyday life. So, and more of this, it is the desperation imposed on the family constraint to have a assisted reproductive technique has also increased the rate of multiple pregnancies. So as we know as obstetricians, we have difficulty in managing a singleton pregnancies, coming out of the labor room, we are much thrilled. We are in almost an adrenaline rush in delivering a fetus in singleton pregnancy. But in multiple pregnancy, the entire concept here, what we're going to talk is actually old wine in a new bottle. But it's really costly when you have old wine in a new bottle. So as such, multiple pregnancy also bears the roles of maternal fetal hemorrhage, and then the GDM, hypertension, and preterm labor in the aspect of obstetricians too. But what do we see and what are we concerned in the maternal fetal medicine point of view? So maternal fetal medicine point of view, are we going to do an expected management if one twin is at trouble? How are we going to take it up? And they are conceived through assisted reproductive techniques. So how are we going to manage it? Or are we really going down and pushing ourselves to talk about selective reduction at any point of time or at any junction? When do we talk about it, and how are we going to do it? So when these fetal therapies come in saving at least one twin, like doing a laser surgery, and out of doing all this, what are we going to talk to them about the preterm delivery or the miscarriage rate with owing to all these procedures we are going to do? Are we really going to do an expected management? So these are the thought process which keeps running on the fetal medicine consultant. How are we going to manage them on continuing the monitoring only using ultrasound? Or are we going to do an invasive intervention at any point to do any management for these twin pregnancies? So as we all know, the scope of my talk and the objective of my talk is going to be about dating the twin pregnancy, as we all know, determining the chorionicity and amnionicity, the twin labeling, screening for aneuploidy, which always raises a concern now, the prenatal diagnosis of aneuploidy, screening for structural abnormalities, discordant twin pregnancies, selective termination when required, how are we going to monitor them for preterm birth, and screening and diagnosis of management of FGR, and complications unique to monochorionic twin pregnancy, and so on. So this is going to be a very basic run through, and how are we going to manage the twin pregnancy, multiple pregnancies. So dating of twin pregnancy, we all know CRL measurement is between 45 to 84 millimeter. That is from 11 to 13 weeks plus 6 days is going to be done. Spontaneous conception, we date them with larger of the two CRLs. We measure the two CRLs according to the guideline. I'm not going to get into the guidelines saying how are we going to measure the CRLs. We are going to take the largest of the CRL and correct the dates for that pregnancy. If small CRL is used, believing the bigger one is grown big, it's falsely reassured the smaller one is still growing appropriately. So correcting them with a larger CRL makes more sense, so that we are able to find the percentage of discordancy, and how are we going to manage them in the following scans. In case of IVF, we are going to use the oocyte retrieval date or the embryonic age from the fertilization. If all that is all done, as still we have in our country where these pregnancies are presented to us only in the early second trimester, we use the head circumference of the fetus, and again it's the larger head circumference of the fetus. Irrespective of the chorionicity, we use the larger head circumference after 14 weeks. So the take home point here is, correct them with the larger CRL, and the CRL to be taken in an appropriate guideline. In case of IVF, use the blastocyst transfer date or the embryonic transfer date. So determination of chorionicity plays a major role in the subsequent monitoring of the entire pregnancy, and plays a major role how are we going to counsel the patient right from the first trimester. So best determined again in the 11 to 14 week scan, which is a very important scan now, where the Fetal Medicine Foundation, where we were using, completely turn the pyramid of care towards the 11 to 14 weeks. Usually with the NT scan, we determine the chorionicity. When amnion and chorion have not yet fused, before that we need to determine the chorionicity. So as we can see here, we use the lambda sign in the dichorionic diamniotic pregnancy, where you can see the two separate placenta and two separate sac. In early gestation, we see two yolk sac and two fetal pole with a nicely separated membrane in between is your dichorionic pregnancy. Whereas in monochorionic diamniotic pregnancies, we see two yolk sac and a very thin membrane which is floating across each fetus, across the fetuses, is the T sign, and this determines the monochorionic pregnancies. Whereas in early gestation, they have two yolk sac and two fetal poles with a very thin membrane between them. Whereas in monochorionic and monoamniotic pregnancies, we don't see the membrane at all, and we can see only one yolk sac in the early pregnancy scan. Why this chorionicity is very important is that chorionicity has to be chorionicity helps in managing the entire pregnancy is one concept, and in chorionicity ultrasound image is to be recorded right from the early pregnancy scan, which helps in future reference. I will tell you in my future slide how this chorionicity is going to help us in the managing the entire twin pregnancy. So as we all know, it is between 13 to within 14 weeks the chorionicity should be determined, is the ISWA guidelines 2025. If you are not able to determine the chorionicity, please refer to a tertiary care center with a fetal medicine consultant where it can be done. When in doubt, when you think we are not able to determine the chorionicity, when you have suppose you have both the placentas or posterior placenta, and viewing the membrane in between becomes very difficult, and to get and seeing the two yolk sacs or two separate fetal pole becomes very difficult. When in such doubt, and you have a patient most commonly presenting in the second trimester, please treat them as a monochorionic pregnancy. So when we are treating them as monochorionic pregnancy, we are increasing the survival dates, so that more surveillance is given to this kind of pregnancies. So why determine the pregnancy? Rate of complications are more in monochorionic twins. Specific to monochorionic twins needs frequent scans, as I was telling you, and the timing of delivery too depends in the monochorionic twin pregnancies. So the complications which the monochorionic twins face are the selective fetal growth restriction, about 14%, TTTS about 15%, single fetal demise up to 1 to 2%, and TAPS, twin arterial perfusion syndrome, about 3%, and the TRAP about 0.1%. And when compared to all this, when you see other complications like miscarriage, perinatal mortality, preterm labor, FGR, and other structural abnormalities, all the percentage goes more towards the monochorionic twin pregnancy. So once we label the pregnancy as dichorionic or monochorionic from 11 to 13 weeks scan, it is very easy and very specific, and we can give a treatment plan to the patients. So once we have determined the chorionicity, in the 11 to 14 week scan itself, how are we going to label the twins? So how are we going to label the twins? So how do we label? We follow a reliable and a very consistent strategy. Label according to their site, either right or left, or lower or upper. And our mapping in the first trimester according to the insertion of cord related to the placental age. We commonly now take the whatever is presenting near the cervix to be the fetal A with reference to the placenta. So in your first image of while doing a scan for a twin pregnancy, first image should be determine the chorionicity. Just label them, it's DCDA or MCDA, and make sure your membranes are marked across in that image. Subsequent image, the second image of it should be followed by an image showing fetus A, whether it is maternal right, maternal left, or what is your placenta. So fetus A, whether it is maternal left and down and the placenta is posterior. And the third image should always be fetus B, placenta anterior, maternal right, upper quadrant. So once this clarification is done right from the 11 week scan, or when you're starting to see the patient at any point of time, this gives much clarity, and the workflow and the scanning technique also becomes very easy. And in subsequent scans also, these records are kept very precise, and these images are given to the obstetrician or to the patient, and the clarity is given right from the beginning. So information should be documented to ensure consistent labeling throughout the follow-up scans. So in your first trimester scan, if you have labeled these pregnancy as right and left upper, according to their placenta and according to the reference of your A, left or right and everything, this has to be taken up to the target scan, and from the target scan and then on, whenever you follow the patients, this 3 points has to be documented in your report. So the first formatting of your report should have that what is a chorionicity, whether it's a dichorionic diamniotic pregnancy, how is the fetus A and how is the fetus B, right or left or upper or lower, should always be determined, and the site marking has also be done in your report. And these 3 points must be there in all our reporting format. So issues in labeling. When there is issues in labeling, accurate retention of labeling throughout the serial scans, because same operator. So once you keep a hand on the twins to scan, you make sure it's the same operator to complete the scan. And labeling for samples. If you're doing an invasive technique, whether it's CVS or amnio, from whichever fetus you're taking, it is very important when we are labeling for a sample. And sometimes perinatal switch phenomenon can happen. Fetus A may not be the first one to deliver in Most commonly in cesarean section, fetus A might not be the one which is delivered first, because fetus A must be labeled near the cervix, and obviously we're not going to deliver the fetus A by cesarean section as the first baby. Lab issues in labeling. So please check with the lab. So whenever labeling is done, and if you're doing that, following that labeling for doing an invasive technique, please make sure the samples are labeled accordingly. Or if there is any other fetal therapy technique you're going to do, make sure the labeling helps and the cord insertion site helps in doing the procedure too. So implications, after we have measured the CRL, we have labeled and we have determined the chorionicity, we have done a beautiful first trimester scan where we have measured the CRL or the NT. So what are the information are we going to do from the NT? The mid-sagittal plane when taken in an NT measurement can give us a lot of information with respect to lot of anomalies which can be detected in the first trimester. The one mid-sagittal section in the CRL can give us lot of thinking about what anomalies can pop up and whether the structurally the fetus is normal or not. So the management of twin pregnancies with CRL discordance of more than 10% or the NT discordance of more than 20% should be discussed with the fetal medicine consultant. Detailed ultrasound assessment has to be done in your subsequent scans or in the same scan with other additional markers to be evaluated. So risk of fetal anomalies, 25% with CRL discordance of more than 10% compared with 4% in CRL discordance of less than 10%. So CRL discordance, if you notice in your early viability scan, early pregnancy assessment scan at 7 to 9 weeks is a predictor for risk of single fetal demise in the first trimester, which has got a deduction rate about 74% and a false positive rate about 5%. So discordant NT, how are we going to manage in DCDA? Think of karyotype discordancy. So you go ahead and do a sampling of both the fetuses. In monochorionic pregnancies, as they have a shared placenta, as all of us know, the monochorionic twins have a higher percentage of increased NT because of vascular anastomosis and fluid imbalance. And mostly monochorionic pregnancy are not at higher risk for T21. Please check the cardiac and other defects when you have the increased NT in monochorionic pregnancy. So what are the other markers? Other markers, nasal bone doesn't play a difference in monochorionic or dichorionic twins. Ductus venosus and tricuspid regurgitation, if present in a monochorionic or in monochorionic, please check for cardiac defects. In dichorionic, it could be a marker for any of the aneuploidy, and that we are going to do in the invasive testing and find out. So after we know what is the chorionicity, we have labeled the fetus, we have set the fetus to aneuploidy screening. So when patient is going to present to us from 11 to 14 weeks, what is your treatment plan? How are we going to give a plan to the patient? How frequently are they going to visit us in the antenatal clinic is very important from the obstetrician point of view and too from the fetal medicine point of view. So if it is a dichorionic pregnancy, after dating, labeling and chorionicity and determining the aneuploidy screening, we need to do a detailed anatomical TIFA scan at 20 to 22 weeks, where do a detailed anatomy, biometry. We see the amniotic fluid volume, preferably the single vertical and the cervical length to predict the preterm labor. From there on, every report should say that assessment of growth is to be done every 4 weeks. The fetus needs assessment if they are appropriately growing, there is no discordancy between both the twins. So these kind of twin pregnancies come to us at every 4 weeks for a surveillance. During the surveillance, what all we survey? We survey the growth, we survey the amniotic volume, and in addition to these 2016 to 2025 guideline, we are asked to do fetal Doppler in every visit for the pregnancy up to 37 weeks. So we plan a pregnancy from 22 weeks. From there on, every 4 weeks, the patient has to come. This has to be insisted by the obstetrician and the fetal medicine consultant in the every antenatal visit, which also needs to be implicated in the reporting format of the your ultrasound report. So monochorionic twin pregnancy, here comes the most danger type of twin, where we see the dating, chorionicity, NT, and you do the aneuploidy screening, everything we do it in the first trimester. But what are we going to do additionally at 16 to 18 weeks is we are going to do the fetal growth, deep vertical pocket, and the umbilical PI. Why is this? Because we are going to see if there is any unique complications to the monochorionicity owing to the sharing of the placenta because of the anastomosis. If there's something happening here, we are doing a detailed anatomical screening from 16 to 18 weeks, and we are subjecting whether these kind of monochorionic pregnancies or these babies are going to get into any complications? Do they require even more frequent surveillance, or the common surveillance which is done every 2 weeks is enough? All this has to be decided from 16 to 18 weeks. Though any problem can pop up at any point of time, only from 16 to 18 weeks, when the placenta takes up for the growth of the fetus, the most anastomostical complications occur in the monochorionic pregnancy, and we start screening them from 16 to 18 weeks. And from 16 to 18 weeks, every 2 weeks, we do a detailed anatomy, biometry. So we do detailed anatomy, biometry, deep vertical pocket, umbilical PI, middle cerebral artery, middle cerebral PSV, and the cervical length, which is done at 20 weeks. From then on, you can see that what we do in dichorionic, we just do them a screening Doppler here. But what has been specified in monochorionic pregnancy is you see an umbilical artery PI, and it is not the MCI PI, it is the MCA peak systolic velocity. And in the coming up slides, you know why this MCA PSV is monitored, and why are we monitoring from the 16 to 18 week, from 18 weeks, especially not at 16 weeks, especially from 18 weeks, why this middle cerebral artery PSV is monitored. And this all has to be recorded in your report. If there is any discrepancy in the growth or anything, additional Dopplers may also be included, which will also help us in the surveillance and the decision factor in the monochorionic pregnancy. So monochorionic pregnancy, we monitor them at 11 to 14 weeks, and after which we call them at 16 to 18 weeks for as an early target scan. We do a screening, we do a Doppler in addition, and from 20 weeks, every report of a monochorionic pregnancy should have a Doppler report too, indicating not the MCI PI, it is MCA PSV, which needs to be saying there is no fetal anemia in the monochorionic twin pregnancies. So as I've made very clearly, this is 4 weeks monitoring, and with the Doppler, here it's 2 weekly monitoring with all the Dopplers, and additional Dopplers may be required owing to the complications of the monochorionicity. So this study pamphlet or this patient information pamphlet has to be given to the patient, telling that how frequently monochorionic should come for a visit, what are the complications that can happen at any point. These complications can happen, and why are we monitoring these pregnancy at a very close surveillance. So screening for chromosomal abnormalities. So what we can do after we have done what we can do for chromosomal abnormalities is, when we see a first trimester screening report in dichorionic pregnancy, we see them, they are calculated for the individual twin. That is, for fetus A and fetus B, you get an individual risk strategy. Whereas in a monochorionic pregnancy, they are calculated entire. This is not monochorionic monoamniotic, but that is monochorionic pregnancy. It's calculated for the entire pregnancy. So you can use the combined screening NT, beta HCG, PAPA, and the NB status also. In as compared, it has got a same detection rate and same false positive rate compared to the singletons. In IVF conception, we make sure that when we check the report, we see whether the age of the donor is used, if the donor ovum or the donor embryo is used. So when we are going through a short checklist before we are doing a first trimester screening, when we are reading the first trimester screening report, is that first you see whether the chorionicity is implicated. If it is dichorionic, you see whether you see 2 risks. If it is monochorionic, you see 1 risk. Whether the age of the patient or the age of the donor or the age of the embryo is used appropriately. And then you come and see how these biochemical markers have played a role in the formatting the first trimester report screening. So vanishing twins. Many occasions we have seen that many of the twins which are there in the early pregnancy scan assessment do not make it up to the 11 to 14 week scan. So what are the screening strategy for the vanishing twin is that, so vanishing twin is a measurable CRL, and there's a significant increase in median PAPA mom, but the median beta HCG does not get altered. So this causes the detection rate, decreases the detection rate from 85% to 75%. In that circumstance, only use NT and maternal age in calculating the risk strategy for pregnancy or any dichorionic or any pregnancy with one single fetal demise. So next is your cell-free DNA. Cell-free DNA is a revolutionized, most costly and the most valuable prenatal screening method. In dizygotic twins, only one fetus is likely to have an aneuploidy. The contribution of cell-free DNA of the 2 fetuses into maternal circulation may vary. That's why the fetal fraction also vary. So when NIPS is a very good test, and it can be used, and it has got a detection rate about 98% and a false positive rate of 0.05%. And according to techniques from last 20 years, this is also one of the most screening, one of the most available and one of the easiest screening test available in twins. But what we should really know is, when are we not going to do NIPS, is when we have a vanishing twin again. In I order multiple pregnancies where they have triplets or quadruplets, which is conceived in the early pregnancy and then they become twins, can we use NIPT? No, we cannot use. Post-fetal reduction, spontaneous reductions, or it is an interventional reduction, we don't usually offer NIPS in these scenarios. So this is what we need to know, is that when do we use screening and when do we not use screening method. In these circumstances, only the maternal age and the NT is used. So after all, finding out whether they are aneuploidic fetus, setting up the monitoring plan and the chorionicity, what we are going to check on is are we going to do invasive testing if any special circumstances occur. So CVS, chorionic villus sampling, should be preferred to amniocentesis in DCDA twin, as it provides an earlier prenatal diagnosis. In monochorionic twin pregnancy complicated by discordant anomaly, the option of dual amniocentesis should be considered, because with single placenta we won't be able to do chorionic villus sampling. So what is it? Once we know they are assisted reproductive technique conceived patients, once we talk about invasive techniques and we talk to them about the miscarriage rate, entire thought process change from the patient, whether they continue the entire pregnancy, how to manage this manage it, are we going to kill the fetus, all like that. But now overall we have understood that amniocentesis and no amniocentesis, you can see the pooled overall data of this 2024 article saying that there is not much miscarriage rate in doing any of these invasive techniques in twins or in singletons. So it's a most safest procedure which can be done. So after explaining talking to them about the invasive technique, we need to understand what is the method to screen for risk of preterm in twin pregnancy. Cervical length measured usually by transvaginal scan is preferred as a screening modality in for preterm birth in twins. 25 millimeter or 2.5 centimeters are mostly used as a cutoff from 18 to 24 weeks is your guideline. Cervical length should be measured at the anatomical screening scan, and in case of additional factors, once again in less than 24 weeks if required. So cervical length less than 2.5 at 20 to 24 weeks, we have a pool data saying that preterm likelihood ratio to have a preterm birth less than 20 or 28 weeks is more. And cervical length less than 25 weeks at 20 to 24 weeks, moderate predictor of preterm birth of less than 34 weeks, but not less than 37 weeks. So when we're doing cervical length, we need to take a few precautionary measures saying this is additional pressure due to the probe, or there's maternal bladder is completely empty. All these steps and adequate protocol has to be followed when we are measuring this cervical length, especially in twin pregnancies, because this is going to one of the scenarios which is going to predict and tell us whether these twins are more chance of having any preterm birth and how rescue methods can be taken up. So prophylactic usage of progesterone is not recommended for prevention of preterm birth in unselected twin pregnancy. Prophylactic use of vaginal progesterone may be considered in twin pregnancy with cervical length of less than 2.5 25 millimeter. There are current evidence stating that routine screening with fetal fibronectin, insulin-like growth factor binding protein, or placenta alpha microglobulin is useful in, does not suggest any of these as a screening method to predict preterm birth. So a combined strategy of physical exam indicated cervical cerclage, tocolysis may be considered in asymptomatic twin pregnancy with dilated cervix less than 24 weeks. Cervical cerclage may be considered when the cervical length is up from less than 1, that is 15 millimeter, when it is less than 24 weeks. So after finding the preterm and everything, so what are the methods of selective reduction? Can we opt in dichorionic and monochorionic pregnancies? In dichorionic pregnancy, trans-abdominal ultrasound guided 22 gauge needle can be inserted in the intracardiac portion of the fetal heart, preferably in the first trimester with 15% KCL or 1% lignocaine. When the diagnosis of discordant anomaly or aneuploidy anything is found in the second trimester, women may opt for late selective termination in the third trimester if the law permits. So what are the options in monochorionic pregnancies? Is cord occlusion, intrafetal coagulation, laser, or radiofrequency ablation. Survival of more than 80% has been proved in any of these fetal therapy techniques. Premature rupture of membranes and preterm birth less than 32 weeks is about 20%. And advanced neurological sequelae can happen if we have reduced one of the twin and there's neurological damage to the surviving twin. So next factors come. We have seen preterm birth. We have seen screening for aneuploidies. We have seen preterm birth, and now we are going to talk about selective growth restriction. One of the fetus with estimated fetal weight of less than 10th percentile or intertwin of estimated fetal discordancy of more than 25% needs an alert. So if any of the twin has got an estimated fetal weight, the combined estimated fetal weight of less than 10%, or the discordant between both of them is more than 25%, we need to press the alarm button and we need to plan the we need to see how the entire pregnancy is planned for either if it's dichorionic or monochorionic. A discordant cutoff of 20% seems acceptable to distinguish pregnancies at increased risk of adverse outcomes. So in our Indian scenario, when these patients are not, this is where surveillance plays a very important role. In our scenario, when we ask the patient, you come every month, we have to do a scan, you have to pay for the scan, you have to get a scan done. You come every 2 weeks, you have to pay for the scan, you have to pay for the Doppler, and you have to do this. Most of them don't turn up. So that's the reason when these complications are more common to arise in twin pregnancies, it is more important to make an monitoring plan for these patients so that the entire pregnancy is given an option and they are well prepared to continue the entire pregnancy. So selective growth restriction, where we see unequal placental sharing. Here, in monochorionic, it is a good placenta. Placenta is not playing it's not the placenta which is doing something bad here. It is because of the anastomosis, arterial anastomosis and arterial venous anastomosis, either superficial or the deep anastomosis is causing complications unique to the monochorionicity, and then that's why this unequal placental sharing comes and plays a role in the selective fetal growth restriction. But here in dichorionic pregnancy, we can see the placenta bad because of any of these additional maternal factors like hypertension or preeclampsia. The placental dysfunction itself plays a major role in causing discordance between the two pregnancies. So selective growth restriction, superficial anastomosis is the most common reason because of the arterial anastomosis or the venous anastomosis. They run parallel on the placental surface on their bidirectional flow. So this arterial anastomosis, when there is a flow, it is like a double-edged sword, as I will explain you here. There is inflow of blood and there is outflow of blood. It keeps going and coming. Whoever tries to take some more and they tries to take the more, another one is deprived, they fall into selective IUGR group. One is taking more, because one is taking more, one wants to give more, plays a role in the TTTS. So this is a double-edged sword in arterial anastomosis. Helps the FGR baby to grow because it's giving blood to the baby which needs blood. So the FGR baby grows. But whereas in TTTS, it's the other way. Susceptible to all the pressure changes, and there is neurological damage in the when there is co-twin demise. So the diagnostic criteria is solitary criteria is when you take the estimated fetal weight less than 3rd centile. When you take at least the contributory criteria of almost any of the two of the three, like estimated fetal weight less than 10th centile, fetal discordance more than 25%, and umbilical PI more than 95th percentile. If any of these two changes the meets the criteria, then we brand them as selective fetal growth restriction, and depending on the discordancy, we plan their management. So how do we differentiate from TTTS to FGR? Hydramnios is present in recipient sac. Normal amniotic fluid is seen in the appropriately grown fetus, okay, whereas hydramnios is seen in the recipient sac. So you have the growth restricted twin becomes a stuck twin in selective fetal growth restriction, and the stuck twin is the donor twin and in the TDTS. So when we find the other factors and we try to differentiate them from all other complications of fetal growth restriction and TAPS or TRAPS or TTTS, then we are after doing all the surveillance, we bring them and see whether they are TTTS or FGR. One has got more liker, one has got less liker. So with these differentiating factors, we'll be able to say whether they are TTTS or selective growth restriction. So depending on types of selective growth restriction, we have types depending on the umbilical artery flow. Type 1 is where the diastolic flow is present. Type 2 is when there is persistent absent end diastolic flow or reversal. Type 3 is when there is intermittent absent or intermittent absent or reversal in the umbilical artery flow. So what is the management of twin pregnancies with selective growth restriction? In dichorionic pregnancies, depending on the gestational age, selective growth restrictions can be managed as singleton pregnancies. There is little evidence to guide the management of monochorionic pregnancies affected by selective growth restriction. That is, we don't have a strict protocol that's saying that 26 weeks you do it, 28 weeks you do it, 34 weeks you do it. Depending on the doctor changes and the gestational age, we take a clinical management situation in these kind of pregnancies. So options can be conservative management or expectant management, what we can do, followed by early delivery. In cases of monochorionic pregnancies, when required, we can do laser ablation or cord occlusion. So what is a follow-up protocol? Where in dichorionic pregnancy, we follow them every 2 weeks depending on the severity. In monochorionic, fetal Doppler should be assessed at least twice weekly. If there's a substantial risk of demise of the smaller twin, then if it is more than 26 weeks, deliver them. If it is less than 26 weeks, consider selective termination by radiofrequency ablation. So in type 1, we try to extend the fetuses up to 34 to 36 weeks and give an optimal outcome for both the twin pregnancies. In type 2 to type 3, 32 weeks or earlier, if there is any deterioration, it's better to deliver them and push them into the NICU for further care. So what happens in a single intrauterine demise in a monochorionic pregnancy is that refer to the fetal medicine center. We need to do a detailed anatomical scan where we see the umbilical artery, MCA and the DV Doppler, counseling regarding the neurological morbidity about 25% in the monochorionic pregnancies and whereas 2% in the dichorionic pregnancy. And fetal biometry and Dopplers needs to be done every 2 weeks and fetal MRI 4 to 6 weeks after selective intrauterine growth restriction. And if there is any if TOP is attempted, you please send the fetus for autopsy and see what has happened. Otherwise, deliver them at 34 to 36 weeks after steroid. So what are the unique complications owing to monochorionic twin pregnancy? As we all know, the TDTS, TAPS, and the TRAPS. Very, very brief description. These are all the diagnostic criteria where we see oligopoly, we see the stomach and the bladder. And when we meet all these criteria, then we diagnose. When we have these suspicion criteria, we put them into the bracket of TTTS. And what is and we know the quintro staging of TTTS 1, 2, 3, and 4, where the 4 and 5 obviously we're not going to help. If we are finding them in your monitoring stage of 16 to 18 weeks, if there's poly and oligo, and the stage 2 where the bladder and the donor twin not visible on the ultrasound, first stage 1 and stage 2 with the ideal placenta and mapping, with a good cervical length, these pregnancy have a good outcome when fetal therapy and fetal procedures are intervened. So laser ablation is a treatment of choice at stage 2, 3, and 4. Conservative management with close surveillance or laser ablation can be done in stage 1 with a long cervix. When laser expertise is not available, serial amnio reduction is an acceptable alternative for more than up to 26 weeks. How TTTA should be followed and what is the optimal gestational age for delivery. So every 2 weeks you keep monitoring them and reducing to alternate weeks following a clinical evidence of resolution. And in case of selective intrauterine demise post laser, brain imaging has to be done after 4 to 6 weeks from the date, and neurological assessment at the age of 2 has to be done. So the mean gestational age where you can deliver with a uncomplicated procedure and owing to the preterm birth is at about 34 weeks. So the next one is the twin reversed arterial perfusion, where there is no cardiac activity in your early scan with variable degrees of deficient development of head and upper limbs and hydrops. When we see this, we suspect a twin arterial perfusion syndrome in monochorionic pregnancies. So how do we monitor them? The risk factors include here are the demise of the co-twin, preterm birth, high loss rate when between diagnosis in the first trimester and planned intervention at 16 weeks too. So a prenatal intervention at appropriate 16 to 18 weeks can help to extend the survival rate up to 80%. Low very preterm birth is very early versus the late intervention. So twin arterial polycythemia sequence, the prenatal diagnosis of TAPS is based on the discordant MCA Doppler abnormalities. Little evidence is there about the outcome and optimal management of TAPS, and screening is why this is where your MCA PSV plays a very important role, where we have replaced the Doppler management in your setting up the monitoring protocol, where the MCA PSV should be measured in all monochorionic and during follow-up of any treated TTTS pregnancies. And the prevention can be what procedure can be done is for do a laser ablation by the Solomon technique. So timing of delivery, uncomplicated monochorionic twin, you can take up to 36 weeks, no increased risk of serious adverse outcomes. Continuing beyond 38 weeks, sometimes there could be a loss of the pregnancy. In uncomplicated pregnancy, elective birth from 37 weeks and continuing beyond 38 weeks increase the risk of fetal death. So on summarizing my entire topic is confirm the chorionicity in the first trimester, rule out malformations, early diagnosis of complications. If variations detected, refer to tertiary care, close follow-up and monitoring, and intervention if required. If possible, please give a treatment plan and a treatment chart, how the surveillance is to be done to every couple, explain them right from the first trimester so that they are mentally prepared and they make a visit to your clinic at regular intervals. Thank you.
Thank you, ma'am, for your valuable talk. Any doubts from the participants? Ma'am, I have a few doubts, ma'am.
Yeah, Shweta.
Yeah, we have a question before that. Is screening mandatory for all twins? I mean,
Yes.
do you mean aneuploidy screening, doctor? I think the question is a little bit. Is screening mandatory for all twins? Is what they've asked.
Yes, ma'am.
I think aneuploidy screening, yeah.
Yes, aneuploidy screening is mandatory for all twins, irrespective of the chorionicity. But in case of vanishing twin, we take only the NT and the maternal age into consideration. So we don't do a biochemical screening, but NT plus maternal age risk stratification has to be done.
Yes, ma'am, that was my question, ma'am. So in case of vanishing twin, if the sac is not there, can we go ahead with the biochemical screening or still?
Yes, it all depends on the first trimester scan done. If you are seeing the first trimester scan images, sometimes second trimester we won't be able to make out the sac or any yolk sac or anything. But you see what is documented in the first trimester. If you have seen, if the person who has done the first trimester scan has documented yolk sac scene, fetal bone flickering scene, that time I don't think it is valuable to give a first trimester biochemical screening. But if they have documented only sac and after which there is no measurement, there is no intra-sac contents, I think we can go ahead giving the biochemical screening.
And I also see sometimes that in case of vanishing twins, I see some reports where they don't do the first trimester screening, but then the patient comes back at 16 or 17 weeks and with a quadruple marker report, which invariably comes with a high risk for neural tube defect. So even that is not ideally recommended, right, ma'am?
16 weeks, if they are doing a quadruple test, again the detection rate has to be explained to the couple. That is, it is only about 60. It is only about 65 to 75%, which is equivalent to a genetic sonogram. That is your TIFA scan, which is done. So getting a positive in a less detection rate test, how much are we going to throw alarm is one thing, and we don't know the genetic component of the baby. That time we say that this has got this test has got a less detection when compared to the other test. So we have other tests which we can do is NIPT can be done up to 20 weeks in our scenario. So you can give an option of NIPT. If the couple is more anxious, the option of even direct testing can be discussed to them.
Okay. And in case of aneuploidy screening in twins, ma'am, if either of the twins have a positive high risk or intermediate risk report, do we have to? I mean, high risk, of course, we are going to do amniocentesis. For intermediate risk, do we do NIPT, ma'am, or?
Yeah, NIPT is an option now given to all couple. So NIPT or amnio is itself, it's a big debate. It all depends on why it has become screen positive. It is because of the nasal or it is because of any other biochemical marker. We need to analyze and sit and talk to them and give an option to them. So NIPT is also a screening test is what has to be emphasized to them, saying that it can, as in my slides, if you see detecting T21, NIPT has got a better detection rate. But seeing T13 or 18, we don't have NIPT playing a major role. Right? So we need to tell them that NIPT also has got its limitation. It is only a screening test. So mostly patients fall in the category getting afraid of getting these needles stuck in. So they go and fall into the category of NIPT. But according to fetal medicine, if you think invasive testing and seeing your karyotype or your microarray in your eyes only will give us 100% satisfaction.
And with respect to fetal reduction, ma'am, supposing we have a twin couple, they don't have any other medical reason, or both the twins are fine on scan. If the couple wants, I mean, they want to electively reduce it to a singleton because they cannot raise a twin or they already have a kid. So is that a valid indication to proceed with the reduction after getting informed consent and all that, or? Because I recently had a MCDA couple. Once we explained regarding the complications of MCDA, they asked whether, I mean, not MCDA, the DCDA couple, they already have a twin, I mean, they conceived through IVF this time. They already have a baby through IVF, and again, they've done a second IVF, and this time it's a twin. They thought they'll end up having a single baby. Now they don't want to continue as twins, so they're asking whether they can do reduction. Is it, I mean, is it a valid reason? Can we do, or
it doesn't?
If they are very
According to
apprehensive.
if there is any maternal reason like chronic hypertension or diabetes,
nothing at all, ma'am. Nothing.
Anything endangering, then for the maternal reason we have done reduction. But for these social reasons to reduce these fetuses, normally structurally normal fetuses don't go ahead with the fetal medicine consultant now.
Okay.
And we have yet the laws and to be framed to say that what all circumstances fetal reduction can also be done.
Okay. And with respect to discordance, ma'am, if there is say more than 20% discordance, but independently when I look at both the babies' fetal growth, the centils are they're normal. They're not like, say, one fetus is having AC in the 15th centile, the other one is having it the 60th centile. Again, do we have to monitor them as growth restricted fetuses, or do they need closer monitoring just because of the discordance?
Most commonly, we don't take the abdominal circumference. It is the estimated fetal weight which is taken into the account. So, so we don't see specifically one parameter like IUGR where we see AC is less than second centile. Please come for follow up. Obviously, when the AC of any of the twin is false, it is going to show a weight discordancy of more than a certain percentage. So if it is more than 15 to 20%, it is better to alarm them and keep, because most of these twins are conceived by ART. So it's better to give an alarming call to them saying that, hey, see, your baby is might be going in a low rate. So you please come for close surveillance. That's all.
Okay. Absolutely. I think we're done with doubts. Any other questions from the audience side? I think that's about it, ma'am. So thank you so much for a very clear and insightful session, ma'am. You've simplified a lot of common doubts that we routinely encounter during managing twins, but I think we will still keep continuing to have all these doubts. So I thank all the attendees for their participation. We hope the session has added value to your understanding of twins, and we look forward to meeting you again in future in our following sessions. Thank you. Thank you, ma'am.
Thank you, Shweta.